Good evening. Welcome to the live surgery session done by the Dentium company. And my name is Jeongcheol Park. I will be a host today. Today's live surgery will be performed by Dr. Jung Jae-wook, and his case will be the iGBR before the implant placement. In this case, the iGBR represents immediate GBR. This is a patient information. The patient is a female, 54 years old. And the chief complaint was my teeth are shaking and hurting. And currently there's a mobility on the 26 and 47, but today's live surgery will be done on the tooth number 26, and which has a severe alveolar bone resorption. Today's surgery plan is immediate GBL after extraction of the 26th tooth number. And of course, we have to remove the complete granulation tissue in order to prevent the inflammation and the infection. And the bone graft that we're going to use today will be the osteum-3 collagen, which is a synthetic bone mixed with the collagen, and the PDLN, which is a polydeoxyribonucleotide, will be used to soak the bone graft materials, which will eventually enhance the angiogenesis, soft tissue, and hard tissue healing. And we're going to cover up the bone graft with the collagen graft 2, which is a 3D matrix made by the collagen. And eventually we're going to cover the bone graft and the membrane all together using the 5-0 nylon, and the hidden X suture will be performed. On your right, this is a clinical picture. As you see, tooth number 26 has a total bone loss, and there's also clinical bone and soft tissue recession. So you may see this in this picture. Today we're going to extract tooth number 26 and do the immediate GBR. The reason that we are not going to place an immediate implantation is because we have no bone here to place and acquire the primary stability. So we're going to place the bone graft only, and we're going to later come back for the implant placement. This is the panoramic view of the patient, the female, 54 years old. The other alveolar bone level is not quite bad, but only 26 and 47 has a severe bone loss above the apical level. So today we're going to place the bone graft inside the extraction socket after extraction, which is an immediate GBR. The procedure, let me go over the procedure again. This is a quite similar situation. After extraction, especially when there is a lot of periodontal bone loss and the soft tissue recession, we prefer to perform the iGBR. We extract the tooth, we completely remove the granulation tissue, and we do the thorough irrigation to remove the debris and also some remnants of the dental calculus or any other foreign materials. And we're going to apply the bone graft. In this case, we are going to apply some of the slight compressive force to apply the bone graft and condense it. This enhances the stabilization and eventually will help to regenerate the new bone better. And we're going to cover up with the collagen 3D matrix. We may use the collagen membrane, but in this case, we're going to use the collagen graft, which is manufactured by Dentium company, which is a 3D matrix. It allows very rapid blood vessel ingrowth, and eventually it will get us to better, wider, and a thicker keratinized tissue, which is called open healing technique. Please take a look at the suture technique in this case. This is called hidden X suture, and actually this was first introduced in the dental publication, which is done by my study group. And this is a sort of the internal matrix suture or the crossed matrix suture, but you have to cross the extraction socket in an oblique way. So you enter from the number 1 position and you go out from the number 2, which is an oblique or diagonal direction. And then you come back from the buccal again, and then you come out from the palatal aspect in a diagonal or an oblique way. By doing that, you may make a cross section above, immediately on top of the membrane, and there is an 11-shaped silk going over the soft tissue. So by doing that, you may protect the membrane and the bone graft, but also you may stabilize it. This is a very critical point, and also there is no buccolingual collapse, which is an ideal situation for the alveolar ridge preservation or immediate GBR. So please take a look how Dr. Jung will perform the hidden neck suture today. We have two similar cases, and let me briefly go over two similar cases, and then we are going to start the live surgery. This is a hopeless tooth numbers 15 and 16. And as you can see from this X-ray, there is a vertical bone loss and also the horizontal bone loss. And especially tooth number 15 looks very severe bone loss is observed. This is a coronal view from the cone-beam city. As you see from the left side, which is a tooth number 15, on the right side, which is a tooth number 16. Yes, there is a very limited amount of the bone, so we cannot place the immediate implantation. Or otherwise, you cannot wait because there will be too much severe resorption of the bone and soft tissue. It will be very difficult to perform the implantation. So in this case, we are going to preserve but also augment the bone and the soft tissue together. How can we do it? We're going to use the open healing technique. This is the biomaterial that I mentioned previously, which is a collagen graft, which is made in a 3D matrix shape. This is not a membrane, which is thicker than the membrane, but it also has a space in the pore structures. It allows rapid vascularization, ideal for the open healing. So after extraction of the 15, we grafted the bone inside and cover up with the collagen graft too. This is a before, and this is the after. In this case, he extracted tooth number 15 first and waited 3 or 4 months later, and then he placed implants on the tooth number 15, and at the same time, he extracted tooth number 16 and performed the iGBR again. So it's kind of a consequential iGBR. So anyway, we can observe the tooth number 15 is made up of a very firm and stable bone regeneration. And also implant has been nicely placed with a great primary stability. So we were able to attach the healing abutments. And also tooth number 16, we performed the iGBR again. And this is an open healing covered with a hidden neck suture. And later, 3 or 4 months later, we can do additional implantation. In this case, we have a bone, we have a keratinized tissue, so there is no reason to open up the flap. We just use the flapless implant approach. And 2 implants are nicely also integrated after 2 months later. So this is the final implant and final prosthesis. So very, very strong and effective way to achieve the bone and the soft tissue at the same time. This is another similar case, and this is, I think, the very important indication for the iGBR. After extraction of the tooth number 36, you may see that there is a huge vertical and horizontal bone loss. If you do nothing, after a couple of months later, it will be extremely difficult to place the implants because there is a severe vertical bone loss, which is quite near to the inferior alveolar nerve. So you may have to do the vertical augmentation with a non-resorbable membrane or titanium meshes, which is quite aggressive. But in this case, if you do the iGBR after extraction, please take a look at the tooth number 35 and 37. They have lost the neighboring bone to the distal and the medial aspect. But when we do the immediate GBR, you may have a chance to nicely regenerate this lost bone, which is a very beneficial to this neighboring tooth. So this is the after extraction, and please take a closer look at the radiograph. There is no bone at the distal aspect of the tooth number 35, but now it has a bone because we have grafted a lot of bone at the distal aspect of the tooth number 35. Also, let's look at the tooth number 37. At the medial portion, 50% of the vertical bone has been gone, but now it has been fully compressed with the bone graft after extraction using immediate GBL technique. Now let's hope that this bone is stabilized and we may place the implants very nicely. We just wait. After 2 weeks later, it is open healing, but don't worry, it will be healed by a keratinized tissue nicely. If you wait 3 or 4 months later, you can place the implants with no problem. But in this case, due to the story to the patient, so we have to wait up to 8 months. Now, we place the implants after 8 months after iGBR. If you look at the radiograph, this is a fantastic regeneration of the bone, especially in the vertical dimension. I'm not sure if anybody can do a better vertical augmentation with this kind of a technique. So easy, so quick, and no aggressive surgery. You just extract it, you just clean it, and you just introduce the bone with a little bit of compressive force. And if it's stabilized, this is the result. Take a look at the distal of the 36 and medial of the 37. We have a vertical augmentation and also nicer regeneration of the PDL space too. So this is a fantastic chance to regenerate the lost periodontium. It was so easy to augment the bone, and if you just wait enough time, then we will be happy to place the implants. And in this case, again, because there's a bone, there's a keratinized tissue, there's no reason to open up the flap. You just place the implants using flapless technique. And this is a final prosthesis, and the patient is nicely and fully functioning. Restoration is rehabilitated with a nice bone and a nice keratinized tissue. So this is the beauty of the immediate GBL. It is not difficult, it is so easy, and the patient is very happy because the chair time is very minimal. So let's see how Dr. Jung will perform the immediate GBL today, which is very impactful, effective, easy, and patient-friendly. So can you show us the video? Okay, the surgery has already begun. Dr. Jung is holding the tooth number 26. Because there is not enough bone, so it is quite easy to extract the tooth. With no fracture, and all of the tips are quite safe, so it's the whole tooth is nicely extracted. And as I have mentioned before, the complete removal of the granulation tissue is very important. So I think that Dr. Jung is ready for the removal of the granulation tissue. Okay, so I think Dr. Jung is controlling the camera to show you the better inside of the extraction socket, but in many cases it's very difficult to directly record inside the extraction socket of the upper molar areas. So I think that this is the best angle right now we have. And he's taking out a tooth blade number 15. You may use the tooth number blade number 12, but in this case it's kind of a direct approach, so there is no need to use the blade number 12. So he briefly cut out and placed the incision along the granulation tissue to kind of make a big circle around inside the extraction socket and cut out the whole granulation tissue. I think that Dr. Jung is trying to take out the whole granulation tissue in a whole, big tissue itself, not being torn and ripped off granulation tissue. And he has using currently a surgical curette right now. It has two curved angles, so these surgical curettes are easy to use. But in some cases, the head of the surgical curette is too small. So in my case, I love to use the surgical curette too, but in my case, I prefer to use the direct, straight approach using the mold curette if the angulation allows. So you may have to be a little bit tricky with the mold curette, but if you can approach inside the extraction socket, then you may scoop up the whole tissue very easily. But in this case, he used the surgical curette, and this is a hemostat. So you can hold the granulation tissue, and then if there's too much granulation, and it will be very, very difficult. Now, this is a big lump of the granulation tissue. I think that there is a lot of inflammation going inside the extraction socket. So he is still going inside the extraction socket to look for any missing granulation tissue. In my clinical experiences, if you miss some of the granulation tissue from the periodontitis, it does not make any big risk. I think it's a calculated risk. So you may calculate what will impact the implant. But if it has been the endodontic inflammation, this is another granulation tissue, he has totally removing the granulation tissue. If it's an endodontic failure or apical lesion, if you miss some of the tissues, you can place the implants nicely, but after a couple of years later or decades later, there are some cases the retrograde periimplantitis happens. So this kind of inflammation is sleeping, and after years and years later, due to some reason we are not sure, but the inflammation inside the bone or some microbes inside the bone kick in and to start the inflammation again. And we may have a loss of the implant. So you have to be very careful to thoroughly remove the granulation tissue at the apical lesions. But in this case, this is a periodontitis affected area. So he's actually removing the tissue from the adjacent tooth. So now this is again, he's kind of using the surgical curette as a root planing technique to remove the calculus or granulation tissue from the adjacent root surfaces because he wants to regenerate the lost periodontium. This is the beauty of the iGBR. As a periodontist, we do many surgeries to restore the lost periodontium, but I think that this is the best time to regenerate the periodontium. This is an osteon 3 collagen. I think it's a 6.52 of this osteogen collagen. And this is a PDLN, transparent liquid, which is a polydeoxyribonucleotide, which is acquired from the salmon, the fish, which is basically a typical fragment of the DNAs. So if you introduce the DNA into this socket, it helps you to regenerate the soft tissue and the hard tissue. It allows the rapid vascularization, and it also reduces inflammation. So I think that it has a bright future in the dentistry right now. And as you see, Dr. Chung has applied the PDLN, and he totally soaked the osteon 3 collagen totally inside the PDLN. So he's not using the cell line at all, and he used the PDLN, total PDLN, I think. And now he's introduced the particles inside the socket. Because this osteon 3 collagen is collagenated, which is moldable, and you can just chew it or trim it or shape it, and you can just condense it. It saves the time. Let's imagine that this graft has been granulated particles. You may use the scoops and 1 or 2, 3. It takes a lot of time, but he just used two scoops, 2 blocks of the osteon 3 collagen. I think that almost half or more than half of the socket is already filled, I think. So he's using the gauze to wipe off the blood and the saline or any liquids to better see the view. Okay, oops, osteochondrial collagen has been dropped. I'm not sure that he's going to use it again. Maybe he's using to use the new osteochondrial collagen. Okay, this is a new one. Now it has been carefully inserted into the extraction socket, and he's using the surgical curette. You may use the surgical curette, or you may use the periosteal elevator, or in this case, my case, I use the end of the periodontal probe. If you have a periodontal probe, the back of the periodontal probe is just like a pencil. So you use the tip of the pencil to apply the vertical condensation force, and it really easily packet the bone graft inside the extraction socket. So as you see, the bone graft has been introduced almost above the bone level. So this is a vertical augmentation, not a ridge preservation. That's the reason that we do not prefer to use the alveolar ridge preservation, because in this case, there's no ridge to preserve. It was almost zero. And this bone graft, as you can see from the mirror view, the bone graft has been newly introduced on top of the previous alveolar ridge. So it's actually outside the bony housing. So that is the reason we use this iGBR concept, because it's not a preservation, but it's an augmentation. This is the collagen graft you may have briefly noticed. This is a square type, 10 by 10, 3D matrix. When it's dry, it's a little bit hard, but if you trim it and if you hydrate it, it becomes very soft. It becomes like almost sponge type. So if you let it heal in an open healing concept, you may think that, oh, I just lost the whole collagen graft, but actually you did not. It has been incorporated into the soft tissue of the patient. So this is not a resorption or necrosis, but it is a rapid incorporation into the patient's soft tissue. So that's it. You just trim it and you carefully insert it and cover up the bone graft. And then without any manipulation, you can just start the suture. I think that Dr. Jung is ready for the suture, I think. Yes. Now he is going to do the head and neck suture that I mentioned before. So you can start from the buccal aspect. One very important thing, you never engage the collagen graft. Once you engage it, when you take out the needle and then the collagen graft is pushed back and forth and up and down, it's very difficult to manipulate it. So you have to always go over the collagen graft. So in this case, he went from the buccal aspect and he came out on the palatal aspect in an oblique way. And then again, he starts from the buccal again. Yes, he's coming from the buccal again. And let's be careful not to disturb the collagen graft. So he has done a very nice movement with the needle and the needle holder to penetrate the buccal tissue and then go over the collagen graft and then engage the soft tissue on the palatal aspect. Now he has come out from the palatal quite far from the extraction socket, right? So it allows better pressing down and the stabilization force if you do this kind of a head and neck suture. Now these crossed silks will better protect the extraction socket. And if you do 2 or 3, 1, 2, or 3, any knots, surgeon's knots, then it is so easily done. So I think that the surgery is almost over and we will come back after break time. If you have any questions, please type in. Okay, now he's applying this is a clinical photo which has been immediately transferred from the operating room. As you can see, the tooth has been nicely extracted, and with minimal manipulation, there is no flap reflection, so the soft tissue is intact. And you see that the pinkish or a little bit darkish thing is a collagen graft too, a 3D matrix made of the porcine collagen. And this is allows the vascularization, protects the bone graft material, and it will be healed by the keratinized tissue. So I think that this surgery has been nicely done, and you see that the hidden X suture is actually nicely protecting all the biomaterial. So if the patient does not do the brushing or finger touching or tongue moving, if there's no mechanical movement, we will be able to remove the suture after 1 week or 10 days later. And there will be a little bit of the whitish or yellowish, somewhat necrotic tissue will be visible. But please do not worry, it will be healed by keratinized tissue eventually. It is already incorporated into the soft tissue of the patient. This is the typical thing you can observe from the open healing. Don't worry. So the surgery has been nicely wrapped up, and there is a question from the audience. There are cases of infection when hidden X suture is applied to the large defect. Yes, thank you very much for a very interesting question. First of all, this open healing is quite strong against the infection. The reason is when you cover up or totally submerge the wounds, then there is a very large or high chance of the infection. But if you let it heal by the open healing, which is a secondary healing, it allows the exudate of the inflammatory materials, and all the cytokines are released out of the wound. So if there's a chance of the infection or remnant of the infection, it slips out of the extraction socket. That is the reason we do not see many infection cases. I've been performing this open healing immediate GBR for more than 7 or 8 years, and there is only 2 cases of the infection. And 2 of them are, I had a wisdom tooth, impacted wisdom tooth, but I did not want it to extract it, so I just performed the iGBR. But there was an infection source from the wisdom tooth, and there was a problem. So if there's not enough, there's not a big problem from the adjacent tooth or apical problem or endodontic problem, then I think that there will be no problem with the infection, and you don't have to worry about it. And also, this infection with the hidden X suture is not a big problem, because this hidden X suture is not the source of the problem. It just protects the wound. So regardless if it's a large or small defect, the only thing you have to remember is the stabilization. If the bone graft and the collagen graft is nicely stabilized using the hidden X suture, then the healing will be uneventful. And I think guarantee that there will be nice regeneration of the bone and the keratinized tissue. But if the sutures are loose or some particles are coming out or the total collagen graft is lost, then there can be a chance of the infection or inflammation. So everything comes to the stabilization. If you can achieve a nice stabilization, the healing will be very, very uneventful. But if you cannot achieve the stabilization or the patient applies any mechanical disturbance, then the healing will be inferior. So you have to remember that the stabilization is the key to the healing of the soft tissue and the hard tissue. So with this final message, we are going to close the live surgery session of the Daintium. Please remind that the next live surgery will be done in May 19th, Friday, and Korea time, 7 p.m. So please stay tuned, and we hope to see you again. Thank you very much.